to the doctor private ethics. No, because of any. You should have your PhD, but you always think. Okay, I think that's.
Okay, thanks. Look in person. Great. Okay, we're starting now.
You ready, Cesar? Okay.
Absolutely.
Let's 12:05, we get started. Welcome to Jousse Lecture, everyone. If you don't know me, I'm Damien Manzone. I'm a postdoctoral fellow here, working with Dr. Jousse Zarifa. And it's my pleasure to introduce everyone to Dr. Parvin Eftekar. And she's an affiliate scientist at Kite Research Institute and the Department of Occupational Therapy at the University of Toronto. And she's an occupational therapist by training. Her area of expertise are neurorehabilitation with focus on stroke, multiple sclerosis, spinal cord injury, and acquired brain injury. Her doctoral work evaluates spasticity using both kinematic and clinical outcome measures to assess the impact of Botox on arm function after stroke. Her current research and clinical practice focuses on patient and family goal-based intervention using the International Classification of Function model. Her research and practice interest area are neuromodulation coupled with traditional rehab modalities such as exercise, task-oriented rehabilitation, splinting after upper limb paralysis, or nerve transplant in individuals with stroke or spinal cord injury. Her postdoctoral fellowship at the University of Toronto was a multi-site randomized trial on studying outdoor activities for seniors. Parvin is a clinical scientist and primary investigator at the Peripheral Nerve Transfer Rehab Clinic at Lyndhurst-UHN, and her role is to develop, lead, and implement rehabilitation elements of the PNT continuum. Okay, so welcome, Parvin.
Thank you for inviting me for this talk. And thank you for your interest about spasticity. I have different clinics with different hospitals. Still, I feel struggle for spasticity. It's hard to kind of patients comes and goes. Tackling, assessing, dealing, focusing, aiming, and intervening, I have to say it's challenging. It's still, after working 10 years, 15 years, focusing on spasticity, it still is a challenge. I try to pull some very recent studies on this topic, on spinal cord and spasticity. And hopefully you will find some information helpful for your practice. I see all of my colleagues are here. That's great. Thank you for coming. I know you have patience. So the agenda, I'm going to go to neurophysiology of spasticity. Very simple, something to learn and take for our practice. And then I will talk about the definition of spasticity and how spasticity manifests in the spinal cord field, and assessments. And also, I'm going to talk about interventions, and I will share some of slides and data that I collected when I intervened. Botulinum toxin plus rehab. So before I start my talk, I always share Botox. First of all, botulinum toxin is the correct term. Botox is one brand. I know in the community everybody says Botox. We know there are different brands. So I will use botulinum toxin instead of Botox. Botox, Xeomin, thus for there are different types. It's similar that we use tissue, we say Kleenex. Kleenex is a brand. So when I say botulinum toxin, means like Botox or Xeomin. So let's start how in spinal cord, after spinal cord injury, we face spasticity. We know when people come to us at Lyndhurst, at the beginning they have spinal shock. Nothing is moving, shocking. They need Hoyer lifter, if they have a power chair, nothing patient can contribute. Flaccidity we use the term, no tone. It takes time. It is the same after a stroke, upper motor neuron. At the beginning, we see flaccidity. Depends on the severity and location of injury. Takes days, weeks, or months. Then patient reports, oh, Parveen, you know, I feel tight when I sit in the chair. My legs are tight, I am tired. So I'm not saying it's 100% spasticity, but it's they are hinting that they are moving away from flaccidity and the tone, abnormal tone is starting. Let's first talk what is spasticity. Kind of accepted common definition. They use different different definitions. I'm going to review very briefly. The major, like the first neurophysiologist, Lance, in 1980, he defined spasticity as velocity dependent. So velocity is the key. This morning I was at Sunnybrook when I was assessing the wrist flexors. I use the muscle very quick. So modified Ashford assessment is based on Lance's definition. So it's the when you move the muscle fast with speed, the reflex you get, that is spasticity. So Lance defined spasticity as a velocity-dependent increased muscle tone when you move it. Then in 2005, Pandian defined spasticity disorder as a sensory motor control resulting from upper motor neuron syndrome, which is correct. Then Ward came up that spasticity is not a single entity and cannot be a universal definition. So that is where we are right now on the definition of the spasticity, but we are still practicing Lance's definition, which he taught in 1980. So velocity, so spasticity when you move, imagine we are assessing the biceps. When you move the limb, there's a resistance in the muscle. So you feel the patient says, oh, when I walk, my wrist touches my neck, my arm hikes up. That is spasticity. And the problem is that the muscle stays mostly in one position. So what happens? The muscle gets shortened. When the muscle gets shortened, what happens? The joint alignment get disturbed. Imagine all the patients we have at the wrist and fingers. What we have. The nails digging to the palm, skin breakdown, malodor. They cannot participate in basic like a winter, pulling their arm through a winter jacket. On top of the definition of spasticity, there are the types of spasticity also add to the difficulty to identify. Sometimes spasticity comes, my patient says, oh, I get at night clonus. Even I get shakiness. Or they say, I get a hand or foot shake. I just get tremor. Or sometimes they get heightened tender reflexes. You don't need to, I just put this list for you to know that spasticity has different clinical manifestations. For us in the clinic, pathophysiology is so important. because it guides our practice. For spasticity, it's important to know that there are two contributing factors. One is optomotor neuron. We know that we have descending pathways, ascending pathways. I'm not going to discuss about that, but the descending pathways, we have two systems, inhibitory and excitatory. When we reach to grab our toothbrush, or eat, there's a coordination. The antagonist-agonist muscles, they work in coordination, no problem. But when we have a stroke or spinal cord, the balance between these excitatory and inhibitory gets disturbed. First of all, for clinicians, spasticity is a lifelong phenomenon. In order our patients to buy whatever we are splint exercise to follow and be independent, we have to educate them. The way I approach, I don't say pathway imbalance, descending, ascending pathways, none of that. I say, remember, we have these bending muscles and opening muscles. Imagine we have two highways, highway 401, highway 407. When the brain works, sends signals properly, it's 50-50. So you can, there's a coordination, you don't get tired, you can put your clothes, you can eat, you can drink coffee. But after something happens, after spinal cord or stroke, it gets 80-20. That is the reason the fingers get flexed. Of course, I don't use flexion, right? I say the fingers are bent. So this is all upper motor neuron. The other pathophysiology is that, imagine the joints, the fingers, they stay for a long time in one position, in a short-term position. What happens? The alignment, the tendon, the capsule. We see all shoulder subluxation, everything. This is also creates spasticity. So for us in the clinic, because I work in the outpatient, your patients, they come to me after inpatient. So it would, I recommend, when patient comes regardless, put them in splint, it helps with alignment. It prevents from exaggerated spasticity. So spasticity is a mixture of both these upper motor, neural, and non-neural components. So I looked at some statistics on spasticity after spinal cord. It's high, and 65 to 93%. Fortunately, the one that the rate on the prevalence on that is really disabling, they cannot do, is not really high, it's 55, but it's still high. We need to focus. But at the chronic stage, now I see those patients. Almost the majority, 70-75%, they have spasticity. I'm not going to go through the definition of complete or incomplete. I know we all know about that. We know that after complete spinal cord, mostly they lose their function is complete. But research shows that, I looked at recent research studies, 30% of them, they still somehow the ascending pathways, they don't get cut. And I see these in the peripheral nerve transfer. Somehow they pass this the suprasegmental and go to the spine. So we shouldn't assume that all motor complete spinal cord, they will improve. So 2% of them, they have a chance, opportunity to gain some hand function. We want to know who are those 30%. And I have to say, spasticity is a biomarker. So if somebody is complete at discharge and they report, I have a spasticity, or you assess, that's a good sign. There are other biomarkers such as neuroimaging, molecular biomarkers, but research shows spasticity is the cheapest and more certain. So that's good that as clinicians we focus. So when patients, they come to us in the subacute, like after they had a surgery, like a Toronto resident, they come to us. If they have complete motor spinal cord, if they report that they have spasticity, it's a good indicator. We should go back and examine their motor function. Again, I know I am repeating, but it is because of residual descending pathways to the spine. But that is not the case in the incomplete spinal cord. Regardless of the spasticity, they improve and they gain function. So in incomplete, we don't need to be very fussy, but people with complete motor spinal cord, it's worth focusing for. One thing I noticed when patients, they come to me, I looked deeper on the pain and spasticity. Sometimes it takes me deeper to examine to see if they have, is this pain or spasticity or both? Are they correlated? Does neuropathic pain causes spasticity, or they are different? So Montero as team, they in 2012, like this year, they looked at on 66 spinal cord population, and they looked at, they had neuropathic and spasticity, and they didn't find any correlation between neuropathic pain and spasticity. So neuropathic pain in that population mostly was in the kind of burning, mostly burning by the pins and needles, and mostly was in their lower back, in the trunk. And in that population, they found 85% they had spasticity. So as I said, in the clinic, the neuropathic pain has no correlation with the spasticity. The other thing is I noticed the concept of contracture and spasticity get used interchangeably. They are very different. The reason we treat spasticity by botulinum toxin treatment, casting, serial casting, splinting, is that not to get contracture. Contracture is that there is no passive range of motion, stuck. So that is the end of it. So that is all this therapy stuff, is that the patient not to get to that point. The muscle get, the muscle tissue gets replaced by fiber tissue and fat. And we refer, at that age, I have few cases that they go to tender release. So I think we get paid. That is our profession, not to get to that point. So the simple way to adapt, we have our dedicated assistants, and then what I do from day first, folks train the families. When you talk, just move there, give them, videotape them. You're gonna sit here, the joint angle gonna be like that. I do it, they watch, they do it, I videotape. So that is the way we can prevent from contraction. I'm just going to very briefly go through how we look at how we can intervene spasticity from different framework. So I talked about spasticity at the upper motor neuron syndrome is the imbalance between two pathways. So this, as I said, the flaccidity, it will not last. So I say when I consult different units, different therapists, I say, put on a splint, keep the maintenance. That is the key. Because research showed that a long time ago, after 3 months, if we don't treat, contractions are gonna kick in. So be pro, train the patient, put the splint, and sometimes I just put neuromuscular stimulation on the antagonist muscles. So that is the key for us. Then biomechanical framework. The biomechanical framework comes again from alignment. You put the splint, you do the weight-bearing stretches. Because when there's a spasticity, look at the flexors. The extensors are overstretched, the flexors are tight. So simple weight bearing in standing. If they cannot stand, mostly spinal cord, I say sit down, put a pillow, and do individually. So in my clinic, really, I approach from, is this upper motor or is this biomechanical? Is both, and how I can address from both angles. This is very old, Gracie's in 2005, but I like this slide because it shows how the problems with stage they kick in. Somebody had a central nervous system, doesn't matter, stroke, spinal cord, whatever. And what is that? They have paralysis. Immediately after stroke, we get rearrangement in the brain, in the spine. So on the right side, patient is immobilized, has pain, it's shocked, mentally, physically immobilized. Then the shortening kicks in. Soft tissue shortening is extremely common. And then if we don't treat, so our role, rehab term, comes from the phrases from the top. As soon as they get admitted here, we have a role. Then at paralysis level, they don't use it. Oh, don't touch my hand, there's a swelling. And we let it go. So that is the area we can intervene. Because on this brain rearrangement, we have not much to do. So that is the way contracture, if we don't intervene, develops. How are we gonna assess? I know you have heard the modified Ashford. You don't need to read, just it goes from 0 to 4. You guys are all 0 because it's a normal tone. So the reason I put 4 is that if somebody gets clonus, I give 4 based on the definition. It looks easy, but because I work in this spasticity clinic, we had to sit down and put guidelines. So for spasticity, if you measure don't do repetitive movement. So we don't jump and move the limb. We sit in a gravity eliminated position and we read the first move. If you repeat, you already impacted the muscle tissue, elongated. So it's so key to know I am going to assess elbow flexors, brachialis, regularly. So, but it's good to know because when you get R notes is mass 2, mass 3, 1 plus, it is impossible you grab any spasticity related study not to include mass. It's not perfect, has lots of flaws, but we have nothing replaced. The only thing is needle EMG, which is very expensive and is not cost effective. So we are stuck with mass. It's not a perfect assessment, but it's a common language in this spasticity world. So in my clinic, when I practice and literature, always recommend to have combined both biomechanical and neurophysiology approach framework. So, first thing is they had a damage in the brain. There's a rearrangement. First thing I say, try to move. I know Chandy and Carrie, they are tired of me saying, push, 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 move, move. So I know you do not see the range, but when the patient tries to move, I put some of the areas in the brain that gets activated. Many, like a motor area, primary motor area, they get activation, even you don't see the movement. So that is the reason I use surface EMG to detect the movements. The graph shows how much the muscle gets activated. Why we need passive range of motion, why we need to teach the family. Family education is the key. They come to see us once a week for 3 months, then they don't see. But family, they are all the time. If you look at my note here, passive range of motion also activates brain, not as intense as active, but it does. So if you have OT assistant, PT assistant, ask them to do. I know they are busy, but teach the family. Everybody has a phone. Take a video, picture. When I print picture, I print 3 copies. One for bedroom, one is in the bathroom, wherever the patients they sit or PSW comes. Splinting. Splinting is I say it's a piece of plastic, but does my role at home. That's what I say to patients. Helps with alignment, swelling. Believe me, it helps with the pain because when they sleep, they get the limb, they get stuck, they get swollen. When they have extended, well-aligned joints, they have less pain. But also, it shows that it may send signal to brain, impact the upper motor improvement. So it impacts the muscle spindle, the muscle tissue, by stretching it. Electrical stimulation is my value. I use a lot. As a clinician, we should know what is neuromuscular electrical stimulation, what is FES, functional. And right now, we are deciding on the parameters of electrical stimulation, which United States therapists. And I am sure something going to come up, and we're going to publish and I will share it with you guys. And I like this device because they can do at home, and also it helps with activation of antagonist and agonist muscles. And if we don't see improvement, we wouldn't see deterioration, or slows down the deterioration. We are in rehab business. Function is our goal. It is impossible, like I say, you will not have the same hand function before your stroke, but your brain gonna be trained. You're gonna strategize. I use this term a lot. Maybe you wouldn't reach the cup like this, but you're gonna find a way to get the cup to your hand. So in practice in clinic, clear communication, sharing literature with a simple language is the key. Botulinum toxin, we know all. That is helpful really, but I always say you have to combine with rehab. Weight bearing is a must, because Botox, you know, peak is at 1 month, then 3 months, then wash off, waiting for next injection, funding. You have to really body up with exercises. The other approaches that I use in passive range of motion, hydrotherapy, heat. My patients are tighter in the winter. I don't know if you have a muscle cramp. People with spasticity get tired because the muscle is firing all the time. So when we deal with their spasticity, they are less fatigued. They participate in their active, basic daily living activity. They have a better quality of life. And funny enough, they fall less. We care, all of us, we care about fall or near fall. So heat is their friend. I buy some devices at home. And constraint-induced movement therapy also I use a lot. I have a map and we follow task-oriented. I started wash apples, grapefruits, not grapes, just gross like big items. Then slowly grade to smaller items. I use imagery, mirror therapy a lot, like is the foundation of my practice. Like getting to the brain, I say, do you floss your teeth? Yeah. I said, yeah, you have a way. Imagining that you're gonna squeeze the sponge after washing dishes. That squeeze is like a flossing the pathways. So that is the key. Serial casting. It's one of our signature. I do only for patients that they are close by, because they come weekly, and I can, if there's some problem, they can drive. If they are far, I don't do serial casting. And literature says 4 times in a smaller muscle like a PRP, DIP, I do for 2 months, but go gentler. And I put the best to the last. Education. Sometimes we just sit and talk. I say knowledge is power. Less pressure on me, on the therapy. More work at home because they see me just once a week. And handouts, pictures, videos. And now they have their own phones. We don't need to worry about privacy, so it's way easier. So this is one of our patients that I did at Toronto Rehab, one of our physiatrists. 95-year-old guy, had a stroke, contractor. He didn't want to go surgery because of our complications. They didn't find he would be a good candidate. So this is digital extensors. We were able to go from, I forgot the exact readings, to minus like a 35, but it took 6 months. So we haven't published, but we have the data. I just want to share the impact of, very briefly, how are we doing with time, Dana?
10-15 minutes.
10 minutes, okay. And I'm gonna leave time for questions. I know I got an email that they want to have a 10 minutes?
Yeah.
Okay. So, for Botox, because I am an OT and I get involved in the upper limb, of course they get Botox in the lower limb, but I looked at the impact of for 6 months, they just got rehab. After 6 months, they got Botox, then continued rehab. So pre and post, the design study. So this guy, I use kinematic markers. I know you guys is a 3D, real time. Is the cameras that they capture, calculate. I didn't do that, I have to be honest. As engineering department, thank God. They use MATLAB. It's just, I was so lucky to have their help. So we measure the impact of rehab and Botox, toxin, on wrist movement. We didn't look at deviation, radial or ulnar deviation. We looked at flexion and extension. And the blue is here unaffected. We measured both sides. And you see that the red is affected. So they have less range. And this is the kinematic markers. These are the shoulder markers. This is the torso. And the mark here are the wrist and palm. And then I looked at elbow, biceps brachialis, brachialis. So I did clinical assessments on top of kinematic, because in the clinical assessments always they say there's the bias component, of course. So we want to really look at, did Botox plus rehab help objective outcomes? So we used kinematic, it's mathematical, we had no way to intervene. So this is the elbow. And so this is the kinematic markers. And I looked at the shoulder. This is the kinematic reading of the shoulder. So these were the kinematic readings I want you to look at: active range of motion, velocity or speed, and trunk compensation. As we know, the other thing I want to say, I really watch the compensation. They do more compensation, there's more weakness. If they have less compensation, trunk compensatory movement, they are more coordinated. So coordination, better posture, these are all hand in hand, comes in improving function. So I looked at mass, then other outcome measures that I don't want to go. So here, for example, hand function, KB, it showed improvement, but not much. Botox, of course, we want the spasticity to go down. It improves the function. Improve the spasticity of function, I am wrong. So here, if you look at the black one, it shows that active range of motion, speed, and compensatory movement. We look at the data, people that were high functioning, they didn't improve. People that they were higher functioning, rehab plus Botox helped them to improve their active range of motion, their velocity, and look at the compensatory movement. They had less compensatory movement. The same for task 1, 2, we saw this trend. So I'm going to end my talk with this focusing on spasticity is a lifelong for us clinicians and patients. They come, they say Botox. We have some lawsuits that patients, they say they're gonna put Botox, function gonna come back. And telling them that no, Botox gonna loosen. The example that I use, I say, do you know these famous people, actresses, they put Botox, you know, they are like this because they want to look like that, because they don't want to get wrinkled. The wrinkles are active muscle movement. They become like this. So using very simple examples and walking through that Botox will not bring you function. You have to work on it. This is one point. The second point is that Botox is a long issue. You need to manage it. That is the reason the name of clinic is Spasticity Management Clinic. We need to tackle from the get-go. So, I am open for questions. I hope you find the talk helpful. I'm sorry, it's more for clinicians. Let's go with the questions.
These are we looking for questions online. Any questions in person? I can start us off with some questions. I'm just wondering, there's a few things that are really cool about your talk, and I'm also one of the clinicians that learned a lot. I'm wondering, how much time do you actually have for patient education? I know you said sometimes you just talk to them, but do you find like it's difficult, or like how do you squeeze that in, right? You say through therapy and also the education.
First session, I just focus on I use COPN, Canadian Occupational Performance. We set 3 goals or 2 goals. What do you want to do? I want to go back to before. I said, yeah, that is our goal. Then it's like a machine. I say, draw a ladder. We want you to be here. Yes. But we are here. Yes. But you know, between here and here, ladder has steps. We're gonna go through steps. We can't bring from here to here. First, what you want to do. Sunnyborough patient, I want to, what I'm doing, Lyndhurst, I want to go back to work. Now, we want to focus on tendon transfer on finger flexors. What about just pulling your pants? Okay. So bringing from going back, he's an electrician, from here to here. It's frustrating for therapists, but we have to learn how to stay calm and slowly, skillfully bring them out. First session, no treatment. Just get some ideas. Where do you live? PSW, skin breakdown. Get to know you. What is spasticity? What is Botox? This clinic is not forever. It's governmental based. You're gonna learn. And then from the following session, do you remember we talked about that? If they until discharge, we review and review. It's hard. You have to understand. It's hard for the patient and families.
Okay, we have a question online from Christina Guy, who is asking, can you describe the characteristics of the patients who most benefit from Botox injection? Who does it work best for?
People that they have real, like a more than like a mass 1+, because I tell my patient, I don't work for Botox company, I don't get commission, but it is not to push you. First of all, prevents from fatigue. So people that they usually have the US system and they have Botox, they have spasticity. Sometimes when the muscles are small or I do first weight bearing stretches with them. I say go for 1 month and come back. Then I see patients with the interdisciplinary. I see with the physiatrist, then we review it. But whoever has spasticity, sometimes spasticity is not, Botox is not only for function. Sometimes they feel tight, especially among after spinal cord. This morning, patients said, "Oh, my husband slides out of the chair all the time." Well, hamstring has a tightness. Position. I did a study. I published. They want Botox even to be able to wear the splint at night. Otherwise, their hand gonna be like a meatball. For alignment, they need splint, Botox, and splint. So I hope, Christine, I answer your question. Whoever has spasticity, they must get. And some education that just botulinum toxin is very focal. They measure the spasticity, they go to the belly of the muscle, better than other oral medication that they take it, then impact on liver, then generalized fatigue. Clinically, I feel botulinum toxin is more effective than oral. Sometimes the level is so high, physicians, they give both focal and oral, but there's their scope of practice. Okay?
Thank you. We have another question online, if I may.
Yeah, go ahead.
Thank you. So this is from Sam Douglas. Thank you for a great talk. You are right that managing spasticity is a lifelong journey for clinicians and patients. But as someone with SCI, I am not going to lie that managing spasticity by stretching, different exercises, etc., can get extremely boring, doing the same things day in and day out for years and years. So then we neglect because it starts to feel a bit old, repetitive, and hopeless. So my question is, how can we make spasticity management fun and motivating? And there's a second question here. Also, not all funding models cover Botox and the frequency and amounts which doctors recommend. How can we fix that?
I don't know, the fun part. I say, I recommend, about boring, I agree, especially in winter, like a Parvin, I live in the basement, I just can't, I have all the pictures, we print color printed, I can't do it. It's the same, last time I want to go for a walk, I couldn't. Yeah, it's every day do the same. I recommend they hire some, you don't need a therapist if you don't have. Sometimes I train in PSWs for families. If they have finance, it comes to money, they can hire some kinesiology students. They come, I train them, family pay them, and then, sorry, maybe they're gonna, these engineers we have, they can create a robot, something to provide. I don't know. I'm sorry, I failed to answer this question, but heat. Yeah, maybe you have to tell me how to do that. I don't know. Sorry.
So, following up on the second question, it says, also, not all funding models cover Botox and the frequency and amounts which doctors recommend. How can we fix that?
Sorry, the funding is not, funding, if people are on OTSP, it's covered, insurance covered, a private, it's expensive, like we are not talking about $50, $200, but they are talking $700, $1,000 each. It's very expensive. Some Zeoman, I know they have a compassion ground. I work in our clinic. We hardly have any, I don't know, they have a, the physiatrists, they have a way to get around. We don't have anyone to pay, except they are from other country, like visitors from United States, they pay from pocket. Sorry, that funding part stuff is not my forte. I don't deal, but you have my email address. I can ask. We have a different team that they communicate with the pharmacy, they constitute, they bring. I don't deal with the funding part. I can get information. I don't want to give wrong information.
I think you have a question on the floor. Yeah, question, right?
I did, but we can also follow up with you after if it related to the serial splinting, whether is that with thermoplastic or is it something more sophisticated?
Because I deal with the hand, if it is gastrocsoleus or ankle, they are bigger muscle. But I use both. I use orthofit and I use soft, and then I give a leverage with thermoplastic. I just want to let you know the rehab world is going away from thermoplastics. They are moving towards them, or like softer, you know. We can talk. In Belgium, and 3D printing. Yeah, I talked to Kyle Lee, and he's going to Belgium like next month. I think we should look at splinting, and we have a 3D. Cesar is running the show. We can start using it. Good question. Okay.
Any more questions from the floor?
Thank you for coming. Thank you for your interest. Thank you, sir.
Or get whether materials are correct.
Yes.